Welcome to The Explainer. Today, we're jumping right into the high-stakes world of trauma surgery timing.
It's the ultimate surgeon's dilemma. When exactly does a life-saving operation become deadly for a polytrauma patient?
This matters because severe trauma is actually the leading global cause of death for people under 40.
Two major philosophies battle it out here: the absolute sprint of early total care versus the damage control marathon.
Now, early total care is the gold standard for stable patients. Fix all fractures definitively within 48 hours.
But for unstable patients, we use damage control. It's a U.S. Navy concept for keeping sinking ships afloat.
So why not fix everything immediately? Well, major surgery acts as a massive second hit to a traumatized body.
Operating during the day's 2 through 4 danger zone can actually trigger deadly inflammation and multi-organ failure.
So, damage control stages the marathon. We control bleeding, monitor in the ICU, and just delay definitive fixation entirely.
See, rapid external fixation saves lives. It completely avoids the immense biological stress of a prolonged, complex surgery.
So you might be wondering, how do surgeons actually choose the right path in the emergency room?
Strict clinical grading is key here. Blood pressure and lactate levels tell us a patient's stability with absolute precision.
If they hit the lethal triad, severe hypothermia, bleeding issues, and acidosis, damage control is instantly required, no question.
The decision algorithm is super clear. Completely stable patients bypass the ICU and go straight to the operating room.
Right, fully stable patients get early total care. This ensures the absolute fastest recovery and immediate pulmonary rehabilitation.
But the real controversy is the borderline patient. They might look stable, but they can suddenly crash post-surgery.
Take pelvic ring injuries, for example. This is the ultimate scenario requiring immediate damage control to stop massive bleeding.
If a patient arrives with a shattered pelvis and crashing blood pressure, aggressive, step-by-step management is absolutely vital. First, we wrap the pelvis. Next, run scans. Finally, use angiography to literally plug up that arterial bleeding. Now, for major thigh bones, early fixation is safe, but only if the patient is perfectly resuscitated beforehand.
Crucially, any operation exceeding 6 hours drastically increases the risk of multi-organ failure. The clock is literally ticking.
Basically, success isn't just about surgical speed. It's entirely about picking the absolute perfect biological moment to operate.
Damage control focuses strictly on minimizing harm and preventing tissue damage, rather than striving for immediate anatomical perfection. Looking ahead, we're already using molecular markers like IL-6 to precisely predict organ failure and dictate surgical timing.
So will molecular biology soon replace clinical judgment entirely for these life-or-death decisions? It's a fascinating thought.